highest level may be at 8 a.m. next day. So there is some controversy, but some authorities prefer to measure testosterone level within 7 to 10 a.m. Testosterone level it is 7 to 11 the maximum, and minimum 8 to 10 a.m. Testosterone level it is 7 to 11 the maximum, and minimum 8 to 10 a.m. period. And there is chances of day-to-day variation of testosterone period. And there is chances of day-to-day variation of testosterone level in hypogonadal men with initial testosterone level less than 300 level. In hypogonadal men with initial testosterone level less than 300 nanogram per dl, 30% had normal testosterone on repeat testing. This is one important information, that normal testosterone on repeat testing. This is one important information. In older men with testosterone level less than 250 nanogram per dl, 20% had. Average testosterone level less than 250 nanogram per dl, 20% had. Average testosterone level more than 300 nanogram per dl over 6 months. If average of 2 samples of testosterone DL over 6 months, if average of 2 samples of testosterone level less than 250 nanogram per dl, none had average more than 300. None had average more than 300 nanogram per dl. So at least 2 testosterone levels should be measured to have one conclusion of testosterone deficiency. One conclusion of testosterone deficiency. Now, the common alterations in sex hormone binding globulin, which will affect testosterone levels. Decreased sex hormone binding globulin levels in serum will increase the serum testosterone levels. Increased sex hormone binding globulin level may also increase total testosterone level. And again, the moderate obesity will decrease total testosterone level, low protein level, hypothyroidism, glucocorticoid or progestin use, anabolic other steroids, acromegaly. And aging initially when the person is anticonvulsant estrogen use, and also HIV/AIDS patient the level of testosterone will be high. And the SS system, the affected by changes in sex hormone binding globulin. So total testosterone may be altered. Free testosterone by analog SS, some authorities are advocating in for few very selective situations, are not affected by changes in sex hormone binding globulin. So calculated free testosterone level and bioavailable and free testosterone level and sex hormone binding globulin in consideration of albumin level is the best one. I will show one apps, you can use this one. And free testosterone by equilibrium dialysis, currently probably we are not doing in Bangladesh this one. And bioavailable by ammonium sulfate precipitation, this is also not used in Bangladesh. So the medications which will decrease testosterone level, these are corticosteroid, ethanol, ketoconazole, and those will bind to androgen receptors like spironolactone. And in many other cases, spironolactone is used as an androgen antagonist. Furamide, cimetidine, decreased gonadotropin secretion will be caused by corticosteroid, ethanol, estrogens and progestins, and other opioids and metoclopramide and other psychotherapy medication may also cause a decreased level of testosterone, and decreased conversion of testosterone to DHT by finasteride. So biochemical definition of testosterone deficiency or hypogonadism, this is again area of conflict, and some authorities will have some level and another have other, but currently Bangladesh we do not have our own level. We are following ISSM International Society of Sexual Medicine guideline or British Society of Medicine guideline in some cases. But AEC, American Association of Clinical Endocrinology, they have fantastic guideline, but it is not updated. That's why we are using ISSM or British Society of Medicine guideline. And they have ISSM, this is the most commonly practiced. This is the target level is testosterone level. If we consider the nanogram per milliliter, if we consider testosterone deficiency, it is less than 3.4 nanogram per milliliter, or in nanogram per DL is less than 340, and in AAC it is less than 2 in nanogram per milliliter, and nanogram per DL is 200. So the term has been changed. Traditionally, we are accustomed to say hypogonadism, but biochemical testosterone deficiency is termed as testosterone deficiency. And it is again confirmed in 2014 by International Society of Sexual Medicine. Hypogonadism is the clinical scenario in totality, but if you measure only testosterone, it is testosterone deficiency. But testosterone deficient patient may have treatment with pharmacological or non-pharmacological manner. Now, a clinical or biochemical syndrome characterized by a deficiency of testosterone, testosterone action, and relevant symptoms and signs, it is testosterone deficiency, and currently this term is being used. And testosterone deficiency may affect the function of multiple organ systems and result in significant impacts, determine the quality of life, including alteration in sexual functions. And patient may come with any of the features of testosterone deficiency. You know, probably somebody knows better than me how the patient are coming to you with their complaints. This is in almost summary of presentations. The patient initially patient may not have any physical presentation. Patient may have psychological presentation. Patient may be depressed, reduced well-being, with low self-esteem and poor concentration, and lack of drive to do any activities. General body effects: decreased muscle mass or increased body fat, and in Bangladesh we are very much familiar to see the abdominal distension in the male, and then abdominal obesity, loss of libido, hot flashes and palpitation, and decreased body hair, and anemia. And one important thing, we are not very frequently saying that the high testosterone deficiency male may present with hot flashes. We very much well accounted with the hot flash symptoms with perimenopausal syndrome, but patient may have. If you ask the patient who are suspected to be testosterone deficiency, many of the patients will say the pattern of hot flashes. Now, patient may present with other complications like osteoporosis, raised libido in rare cases, insulin resistance, and sarcopenia. In Bangladesh, sarcopenia in almost every case is very much pronounced, and some authorities like to say that the increased level of type 2 diabetes patient may be contributed by sarcopenic obesity, increased fat mass, reduced muscle mass. And in reproductive system, the patient may have subfertility, subnormal genital size, a loss of pubic hair, erectile dysfunction, and sexual dysfunction. I will have later on erectile dysfunction tomorrow. And with the decreased level of testosterone, you can see that the symptoms may be variable. At the initial stage, patient will have decreased libido, then decreased vitality, may complain of fatigue, mood changes, insomnia, anemia, delayed ejaculation or hot flashes, erectile dysfunction, decreased muscle mass, increased visceral body fat, testicular atrophy, weakness, osteopenia, and osteoporosis, and loss of facial or axillary or pubic hair. Again, traditionally, we like to ask the question, do you have decreased frequency of shaving? This is the rarest symptoms you can encounter. So generally, patient will not say that earlier I had shape every day. Now I am doing every alternate day. Very rarely patient may come with these complaints. And you can probably clearly assume that how the primary testosterone deficiency and secondary testosterone deficiency occur. The primary testosterone deficiency, it is due to testosterone production from the testes. Secondary testosterone deficiency due to other cause, mainly the pituitary is the player. So when you have suspicion the patient have primary testosterone deficiency, these are the differential diagnosis. Klinefelter syndrome, this is not very uncommon. And XX male, again this is not uncommon. Noonan syndrome, this may be uncommon. Meiotic dystrophy, again not uncommon. Congenital anorexia may be uncommon. Sertoli cell only syndrome, very uncommon. Acquired terminal cell aplasia may be common. And orchitis, very common in Bangladesh. And others, chronic renal failure, liver disease, HIV, AIDS infection, other drugs or X-ray may be contributing to primary testosterone deficiency. And in secondary testosterone deficiency, any cause of pan-hypopituitarism will cause secondary testosterone deficiency. And congenital, these are not common. Isolated hypogonadotropic Coleman syndrome, ARIS or FSH mutations, leptin or leptin receptor mutations, gonadotropic receptor mutations, hypopituitarism and congenital adrenal hyperplasia. This is not uncommon. And acquired hyperprolactinemia, this is a bit common. Gonadotropin releasing hormone analog therapy, glucocorticoid therapy, very common. Critical or chronic illness may be common. Diabetes mellitus. This is, if a patient has diabetes, he will have everything, every bad thing. And opiates abuse, pituitary mass lesion, infiltrative diseases, cellular surgery or radiation, and hemochromatosis. Now, testosterone deficiency in male due to defects of androgen target organs, androgen insensitivity syndrome. Androgen insensitivity, again, not very common, so we will not go in details. Now, this should be kept in mind. Late onset hypogonadism. If you realize the late onset hypogonadism, you will find so many people roaming around you, they have late onset hypogonadism. The other terms, male menopause, male climacteric, andropause, androgen decline in the aging male, partial Adams, and aging male syndrome. But LOA is the term used by International Society of Sexual Medicine. You can clearly assume that with advanced age, the secretion of testosterone will be decreased by lyric cells, as the number of lyric cells will be decreased by natural aging process. And not only that, other causes will aid the causes of primary testosterone deficiency. Everything which will act on testosterone will cause testosterone deficiency. But initially it may not be evident, but if you evaluate the patient may be may have diagnosis of testosterone late onset hypogonadism. And this is the graph clearly showing that with the advancement of the age, the level of testosterone will decline. So most of the patient after the age of 70 may be in the category of late onset hypogonadism. But before that, many patients may have if you evaluate the patient. And some patients may have other causes with increased LH, FSH level or estrogen level and stimulating the hypothalamus. And prevalence, this is not, we have no study in Bangladesh. Most of the studies of LOAs came from Japan. And Japanese people, they have higher life medical education. %, age group is about 23% in community. Again, several studies have shown that they recommended that at present the diagnosis of treatable testosterone deficiency requires the presence of symptoms and signs suggestive of testosterone deficiency. So with advanced age or with some factors, patient may have testosterone deficiency, but without biochemical evidence of testosterone deficiency, we cannot treat. And not only for testosterone deficiency, for every disease, you should have confirmed the diagnosis by biochemical or tissue diagnosis or some other methods. So the International Society of Sexual Medicine recommended making a diagnosis of androgen deficiency only in men with consistent symptoms and signs and unequivocally low serum testosterone level. In previously, it was recommended that only you will measure testosterone level with confirmed symptomatic testosterone deficiency, and this persists now. And Massachusetts male aging study, this is the largest study in the world. The prevalence of rate of androgen deficiency at the study entry without consideration of signs and symptoms and without cut-off of testosterone of around 400 nanogram per DL was estimated to be 253. This group of patients had no signs and symptoms. And then follow-up, the prevalence was 39.3. So there are so many people, community people, they have testosterone deficiency. But considering the presence of at least 3 signs of symptoms and total testosterone level, the prevalence rate is 6% and the baseline 12% at follow-up. So this is the final statement. If only biochemical evidence will not push you to treat the patient, in combination of physical presentation and biochemical evidence, you will treat the patient. European male aging study found that they have a cut of 317 nanogram per DL of free testosterone and 2 point overall was increase of hypogonadism and 0.1% in men aged 40 to 49 and 5% in the age group of 70 to 79. This is very lower level of testosterone deficiency, but current study may show other findings. Boston area community health study found there 5.6% of testosterone deficiency among 30 to 79 years male patient. So now causes of testosterone deficiency I have shown earlier. Now focus on diabetes. Can diabetes cause testosterone deficiency? Yes, obviously. And with poor glycemic control, the level of testosterone may be again very low. So with the metabolic improvement of the patient with diabetes, the level of testosterone may be a bit higher. So depending on the free testosterone, total testosterone, bioavailable testosterone, in all groups, testosterone deficiency in diabetes is very high. And in comparison with that, non-diabetic patient, again, total testosterone in every age group, in all ages, if the cutoff total prevalence 34% in diabetes population and 22.3% in non-diabetic population. Now, how will you diagnose testosterone deficiency? This is the classical pattern. Before going to lab, you will examine the patient physically. Before examining the patient physically, you will have history. And for a patient of testosterone deficiency, the history will not be like other our OPD. So many people are there, so many doctors are there, they are taking the history. This will not help. So one patient, one doctor, this is the pattern, and the room will be for this history taking time, the room will be not allowable for other person, and the patient should speak at his spontaneously, and at the end of the history taking, you will have your questions to assess the statement of the patient. And after having the history, patient have come to you. You did not go to the patient. So patient has come to you, but patient may have come to you with other symptoms. But if you have any clues, the patient may have testosterone deficiency, then you start the history taking in the form, standard format, and you will not forget the past medical history of the patient. For Bangladesh, mumps or orchitis is a bit common. Even in fewer cases, previous history of chickenpox may contribute to cause testosterone deficiency. After that, you will examine the patient. Gross examination, the muscle mass will be lower. There will be abdominal obesity. But in the patient who have no testosterone deficiency in Bangladesh, they may have abdominal obesity. But the patient with testosterone deficiency, they will say that the recent months or in recent years, my abdomen has gone bigger. Then drug history, I have shown the list of drugs. You should be very keen to find out the drugs the patient is taking currently. Now this is again the International Society of Sexual Medicine algorithm to evaluate the patient for testosterone deficiency. Patient may come with fatigue, patient may come with erectile dysfunction, patient may come with subfertility, patient may come with vague complaint. But if you have the interest to evaluate the patient, then again standard format practice you should do, take the history, physical examination, and after that you will send the patient for serum testosterone in the morning. The time we may have debate, but the time, the best time may be with any error 8 to 10, but the maximum range of the time may be 7 to 11 a.m. Okay? But a patient is coming with the report, low or borderline low testosterone, total testosterone less than 12 nanomole per liter. Repeat that total testosterone with LH and sex hormone binding, globulin and prolactin. The patient is coming again with testosterone level 8 to 12 nanomole per liter. With sex hormone binding globulin again plus minus, then reassess, but do not start treatment. Patient is coming with testosterone level less than 8 nanomole per liter with high LH, exclude contraindications of testosterone replacement, and it is excluded, then start testosterone replacement, and if not clearly excluded, review the patient and wait for the review report. And the patient is coming with testosterone level more than 12 nanomole per liter, no testosterone deficiency, seek other causes of the signs and symptoms of the patients. If the patient again while reassessing have low testosterone, low LH, the investigate pituitary and other causes of low LH, and no definitive causes, identify other causes and manage the cause, but the patient do not have testosterone deficiency. So the algorithm is not very clumsy, very straightforward. So what specific point we should consider? If the patient come in the early young age, you can find out the incomplete or delayed sexual development or reduced sexual desire, decreased spontaneous erection, breast discomfort or gynecomastia. This is very much common. loss of libido, loss of body, axillary pubic hair or reduced shaving. It is not very common, and small, less than 5 milliliter or shrinking testicle. Shrinking testicle, it is difficult to find out from the history of the patient, but we can measure testosterone volume by oxidometer. And inability to conceive, this is many patients will come to you with subfertility. And height loss, this is not very common, but testosterone deficiency will cause osteoporosis and height loss. And in young who are not using glucocorticoid, testosterone deficiency is the most common cause of osteoporosis. And again, do not forget hot flashes and in male and sweats. And patient with borderline testosterone level 8 to 12 nanomole per liter, consider additional biochemical tests, gonadotropin, sexual binding globulin and prolactin, and careful consideration of comorbidities before starting any treatment, and calculate free testosterone. The ISSM has one apps, but I do not use because it is online apps. But British Society of Medicine, they are having T calculator. The app's name is T calculator. This is all offline use. You can use both of the calculators is doing very well. Now you have confirmed the diagnosis. Start treatment. How? Who should receive testosterone treatment? Men with clinical symptoms and testosterone level less than 8 nanomole per liter. Men with clinical symptoms and testosterone level with 8 to 12 nanomole per liter, where additional investigation indicate presence of hypogonadism. Older men with significant symptoms like long-term risk or benefits have yet to be clearly demonstrated. Who should not receive testosterone treatment? Untreated or suspected carcinoma of prostate who have PSA level more than 4 nanogram per milliliter. So, before starting testosterone replacement therapy, PSA should be measured. Moderate to severe symptoms of BPAs, breast cancer, liver tumor, significant polycythemia, severe cardiac failure, untreated sleep apnea. How to treat testosterone deficiency without testosterone. The International Society of Sexual Medicine Committee recommends that men who wish to maintain spermatogenesis, fertility and the testosterone volume to be referred to specialist management, endocrinologist or fertility specialist, until an approved non-testosterone is available, because the exogenous testosterone will cause decrease spermatogenesis, will inhibit spermatogenesis. So couple who are rushing for fertility, even testosterone deficiency is there, if they like to conceive, they should not consider for testosterone replacement therapy. Clomiphene cited, this is one area, the older method of treatment. This clomiphene cited blocks estrogen receptors in hypothalamus and pituitary and increases gonadotropin releasing hormone, LH, FSH release, but no consistent effect on seminal parameters or pregnancy rates. Remember that there is no consistent effect on seminal parameters or pregnancy rates. You will see several clinicians are prescribing clomiphene citrate in treating patients with testosterone deficiencies. Aromatase inhibitors is used for secondary hypogonadism as alternative approach to testosterone replacement therapy. Now the follow-up. The effect of testosterone replacement therapy on symptoms reduction are assessed at every inquiry at about 3, 6 and 12 months follow-up, and after initiating testosterone replacement therapy, and then annually. And tests to be covered while following up the patient: total testosterone level, lipid profile, hematocrit and PSA in men with age more than 40 years. Patient should be monitored every 3 to 6 months during first year and at least annually thereafter. Each visit careful clinical and endological evaluation should be performed. Digital rectal examination is mandatory. And PSA and hematocrit again mandatory. Consider prostate biopsy if PSA is more than 4 nanogram per milliliter or PSA concentration more than 1.4 nanogram per milliliter within 12 months of treatment. What is the outcome expected from testosterone replacement therapy? Compared to placebo, testosterone replacement therapy significantly improve all aspects of sexual function in studies of middle-aged and elderly men with low testosterone. And best outcome with the level of testosterone less than 12 nanomole per liter. More severe hypogonadism, more significant or impressive are the result of improvement. Hypogonadism is the main cause of erectile dysfunction in younger men, while it is one of the multifactorial in ED in elderly men. Elderly men may have several other factors. So combination of testosterone replacement therapy with PD5 inhibitor, tomorrow we will discuss on that, can be used to improve the outcome of PD5 inhibitor in hypogonadism, and testosterone replacement associated with reduction in bone resorption and increased lumbar bone mineral density. This is the FDA reviewing testosterone therapies. Testosterone are being used in several countries, but in Bangladesh we have very few molecules, very small amount of molecules in the markets. In conclusion, managing testosterone deficiency, sexual functions such as libido, erection, ejaculation are clearly testosterone dependent, with different testosterone cutoff values regarding onset of clinical symptoms. To get maximum effect of testosterone deficiency, patients with testosterone replacement, PD5 inhibitor should be given to get the maximum effect. And no effect observed on testosterone replacement if the baseline testosterone levels are higher than 12 nanomole per liter. So testosterone deficiency causes erectile dysfunction and low libido, and after testosterone replacement therapy, both function improves. Maximum effect reached after 2 to 3 months. Again, you should keep in mind, and patient should be informed that after getting one injection, you will not have improvement in many parameters. Oral testosterone, again red mark. Oral testosterone, 17 alpha methyl testosterone, is not recommended by International Society of Sexual Medicine Committee on testosterone deficiency patients. At the end, you are welcome to take participation in questions and comments.
Thank you, Dr. Selim bhai. Our question হচ্ছে যেটা টেস্টোস্টেরন আমরা আপ কত বছর বয়স পর্যন্ত দিতে পারবো? অনেক সময় কিছু বৃদ্ধ আসে এজ above 65 or 60 years, তারা বলে যে আমার তো হার্ট ভালো আছে, ভালো আছে, আমার কোনো পিএসএ লেভেল নরমাল, পোস্টের তেমন কোনো সমস্যা নাই, ইউরিনারি সমস্যা নাই, আমার তো দরকার। এরকম অনেক পেশেন্ট বৃদ্ধ আসে, কি অ্যাডভাইস দিবেন?
এটা অনেক ডাউট ছিল যে কোনো এজ মার্ক আছে কিনা, যে আমরা এটা কিন্তু এখনো আবারও হালিমের ভাষায় বলি যে অনেক ফিজিশিয়ান কনজারভেটিভ ওয়েতে ট্রিট করছে, কেউ অ্যাগ্রেসিভলি ওয়েতে ট্রিট করছে। তো কত বছর পর্যন্ত আমরা দিব না, এটা কিন্তু আসলে ক্লিয়ারলি কোনো বয়স বলা নেই। বরং উল্টা কারেন্ট আমরা সেক্সুয়াল মেডিসিনের এইগুলাতে প্রেজেন্টেশনগুলো দেখছি, যতগুলো স্টাডি নতুন নতুন আসছে, তারা দেখাচ্ছে যে যদি কোয়ালিটি অফ লাইফ ইজ ইন কনসার্ন, the patient who are getting testosterone replacement therapy with confirmed diagnosis of testosterone deficiency, the quality of life with them with a placebo or their counterpart, it is better. So there is no need to stop the treatment. whatever may be the age. But if the patient has one ischemic heart disease, one ischemic stroke, then you should stop. Sir.
টেস্টোস্টেরন যে ওল্ড যে দেওয়ার ক্ষেত্রে আর কি যেহেতু কন্ট্রাইন্ডিকেশন তো এগুলো তো আছেই, কিন্তু এটা ফলো আপ কীভাবে বা মানে টেস্টোস্টেরন কোনটা প্রেসক্রাইব করবেন? আমাদের দেশে তো দেখা যাচ্ছে যে টেস্টানন যেটা 250 এটাই বেশি অ্যাভেলেবল, আদার তো টেস্টোস্টেরন তেমন কোনো প্রিপারেশন তো আমরা মার্কেটে পাচ্ছি না। এক্ষেত্রে কোনটা আপনি কোনটা বা আপনারা কোনটা সাজেস্ট করেন?
কারেন্টলি যেহেতু বাংলাদেশের দুটো আছে, একটা হলো ইনজেকশন, একটা ক্যাপসুল। ক্যাপসুল ক্লিয়ারলি নট রিকমেন্ডেড, তাহলে একটাই হাতে থাকলো শুধু। কিন্তু মহিউদ্দিন খুব ভালো ভালো প্রশ্ন করছে। টেস্টোস্টেরন হলো এই অ্যান্ড্রোজেনটা হলো গ্লোবালি নাম্বার 1 অ্যাবিউজ ড্রাগ বাই মেল অ্যান্ড বাই ফিমেল। ওকে, সো ইন দিস scenario is again persisting in Bangladesh. The people are getting testosterone, and most of them are getting testosterone capsules and from the drug shops, not by prescribed, but somebody also prescribing testosterone capsules. If we are bound to maintain the recommendation, because sir has told that the days are coming that if you are not maintaining the recommendation, you may go to court very frequently. So to avoid, and if the patient complain shows you against you in the court, if you maintain the guideline, you are in safe position. So everybody, I should request everybody that you should follow whatever may be the recommendation. You can follow the AC recommendation, then Society of Sexual Medicine recommendation, British Society of Medicine recommendation, and if we have our own recommendation, we can follow this one. You should follow. So, but to respond to Dr. Mohiuddin's question, in other parts of the world, they have testosterone patch, testosterone gel, and in the International Society of Society of Sexual Medicine, they encourage testosterone patch superior to testosterone injection, and testosterone gel also good. But in Bangladesh, we find that testosterone patch, this is the off-level drug. This is coming not so that's proper channel, so we cannot prescribe this one. Yeah, only one we are being in Bangladesh.
আমি একটু যোগ করি, সেটা হচ্ছে এটা ওখানে আপনি ইনজেকশন না দিয়ে মুখে ওষুধ দেওয়া তো ভালো হয়েছে, কারণ মুখে ওষুধে অ্যাবজর্পশন কম। সাবফার্টিলিটি টেস্টোস্টেরন কজেস ফার্দার ইম্পেয়ারমেন্ট অফ স্পার্মাটোজেনেসিস। মুখে দেওয়াতে অ্যাবজর্পশন হয় নাই, যাতে পেশেন্টের স্পার্ম কাউন্ট কমে না, পেশেন্ট বিকাম আনসিম্পটম, ইউ টেকস দ্য ক্রেডিট, দ্যাটস ইমপ্রেসিভ। আচ্ছা, মহিউদ্দিন ভাই যেটা বললেন, ইন পেশেন্ট সিকিং ফর ফার্টিলিটি same thing happening everywhere. Skin specialist কাছে যাচ্ছে যে স্যার বাচ্চা হচ্ছে না, without investigation they are giving the testosterone that causes then oligospermia, then they send to endocrinologist. Mohin bhai যেটা বললো, in case of old age due to low quality index rifia or low physical well-being, low mood অথবা fatigue, there are lots of differential diagnosis. You have to be confirmed that this low physical activity life index or low mood or well-being is due to testosterone deficiency. In that case only testosterone is indicated, because there are lots of differential diagnosis. Weakness, testosterone is the most misused drugs in all over the world. সেজন্য হচ্ছে আর কি। আর বলা আছে ডিউরেশন যেটা বলেন, এটা বলা আছে ইনডিফিনিট, পরিষ্কার বলা নাই।
টেস্টোস্টেরন ডেফিসিয়েন্সি আসলে লাইফ লং, আইদার প্রাইমারি অর সেকেন্ডারি, যার ডেফিসিয়েন্সি লাইফ লং এ। কিন্তু লাইফ লং এ যে এটা অবশ্য লংজিভিটি, যার লাইফস্টাইল যেভাবে যে ইয়ে করতে চায়, এনজয় করতে চায়, তো যদিও কার্ড লেভেলে এরকম ইয়ে নাই, যেহেতু লাইফ লং ডেফিসিয়েন্সি আমার মনে হয় তাইলে আপ টু। কিন্তু
এন্ডোপস ইটসেলফ ইজ নট এন ইন্ডিকেশন ফর টেস্টোস্টেরন রিপ্লেসমেন্ট, এটা মনে রাখতে হবে।
না, তা তো অবশ্যই, এটা তো একটা গাইডলাইন আছে যে টেস্টোস্টেরন লেভেল কত হলে গাইডলাইন, এটা একটা ইয়ে আছে, গাইডলাইন যেটা সাজেস্ট করবে তাহলে সেটাই।
থাকি যে কখন শুরু করা যাবে, কখন শুরু করা যাবে না, এলার্লি পিপল, তাই তো, এরকম তো।
এখন যেখানে যেগুলো মিসইউজ হচ্ছে আসলে কি টেস্টোস্টেরন কয়েক ডোজ দিল বা মাস বা দিল পরে আবার গেল পরে তো আবার টেস্টোস্টেরন আবার বিলো নরমাল চলে আসে।
না আপনার কথাটা কি এরকম যে মনে করেন যে 69 ইয়ার্স একজন মেল আসলো, ওনার এখন মনে হচ্ছে ফিচারগুলো এরকম যে ওনার ডিক্রিজ লিবিডো, সেক্সুয়াল পারফরমেন্স খারাপ, তারপরে আমরা দেখলাম যে টেস্টোস্টেরন অনেক কম, ওকে বিপক্ষে এরকম কি ইস্যুটা? তাহলে এই উত্তরটা দেবে, এটা হলো